Good afternoon, and thank you for joining us for today's webinar, COVID-19 Town Hall for CHWs, Where Are We with Variants and Where Are We Headed, Part 3. My name is Dina Pimenova. I am the Senior Project Coordinator for the Community Health Worker Research and Resource Center, housed in the Department of Population Health at NYU Grossman School of Medicine, and supported by the NYU Langone Community Service Plan. Today's webinar is co-sponsored by the NYU Community Engagement Alliance Initiative, NYU CUNY Prevention Research Center, and NYU H&H Clinical and Translational Science Institute. Next slide, please. Before we get started, I'd like to go over some housekeeping. Everyone is on mute. To enable or disable closed captioning, select live transcript at the bottom of the screen. The chat box is open for comments and sharing of resources. Please select everyone and not just hosts and panelists. Please use the Q&A box to submit questions to the speaker. We will have time to answer as many questions as we can during the Q&A. And stay tuned for an email from me with the slides and recording in the next week or so. And lastly, please be sure to fill out the poll that will pop up on your screen at the end. Next slide. This webinar is geared primarily towards community health workers and frontline staff working directly with community members. We will first hear an update on existing and emerging COVID-19 variants in New York City, and this will be followed by a Q&A. Our speaker today is Dr. Anna Burstein. She's an assistant professor in population health at NYU Grossman School of Medicine. She advises the New York City Department of Health and Mental Hygiene on COVID-19 forecasting. She was previously a senior research manager at the Institute for Disease Modeling of the Bill and Melinda Gates Foundation, where she developed mathematical models for global disease control and eradication. And today's Q&A moderator is Val Fleming. Val is a community health representative in the Department of Population Health at NYU Grossman School of Medicine. In her role, she educates community members on health-related issues and wellness. She attends blood pressure screening events with community-based organizations in the African-American community and will be working with faith-based organizations to provide education on blood pressure awareness. She has 7 years of experience in social services and case management with expertise in mental health and medication adherence. She has a bachelor's degree in criminal justice from Monroe College and plans of obtaining her master's. And with that, Dr. Burstein, the floor is yours.
Thank you so much, Dina, and thank you, Val, for moderating today. Really pleased to be here to offer this update on where we are with variants and where we're heading. And this is part 3 because the picture with COVID-19 just keeps changing. And I'm really happy to take your questions today about how we should respond to all these changes. We'll move on to our first slide, which we're going to be talking about initially just where the epidemic has gone since we last spoke. So, previously we were experiencing these waves of COVID-19, and those looks like some fonts got messed up, but here we have original and then the Alpha, Delta, and then Omicron variants. So we've all lived through these waves, and you probably remember the guidance that we've talked about in previous sessions, which is sort of think of the kind of measures that we take against COVID-19 like a heavy coat that you need to pull out. You should never throw out your heavy coat because it's going to get cold again, but you can enjoy the nice weather in the in-between times. And essentially, we've gotten a curveball from this virus where that guidance is much harder to contextualize now because these waves, what used to be these very distinct waves, have essentially blurred together. So if you look at everything that's happened since about April of 2022, we've basically had nonstop waves. The transmission rate has never got down very low. And so we've had a few ups and downs, and we've been able to identify specific sub-variants of the Omicron variant, all these things that start with the letter B, but we've never had a really distinct variant wave since that time. And so when you look down below, that's led to a pretty consistent test positivity rate, pretty consistent hospitalization rate, and pretty consistent death rate since we went through that large BA1 peak that occurred over the holiday season of 2021 to 22. And then if you just click once on this slide, I think an important thing to remember is that even though we haven't had a very tall peak of a wave, most certainly this epidemic is not over. And really since this summertime, if you look at the mortality rate here in New York City, it's been pretty consistently hovering around 15 deaths per day. And just to contextualize that, there are only about 150 deaths per day just from anything in New York City. So 15 deaths per day means 1 in 10 people who are dying of COVID-19. So that's much better than the number of deaths from COVID-19 being much higher than the typical mortality on any day where the morgues were overflowing, the ICUs were overflowing, but it's still a substantial proportion. It's certainly not an ignorable proportion. So unfortunately, we can't just imagine that the epidemic is over because 10% of our deaths are still COVID deaths. Next slide, please. So just to zoom in on the very end of that deaths trend, deaths are really, one of the main outcomes that we're worried about, long COVID being another one. So here, zooming in on what's been happening with deaths since November. As I mentioned, deaths have been really just hovering around 15 per day, really since the summer through the start of December. And then we did see an increase in deaths, about a doubling actually, over the holiday season. And that may have had something to do with variants slightly changing, but more likely just had to do with people socializing with different social groups than they normally do, traveling around more over the holidays. So we usually expect to see a bump in any transmissible respiratory disease during that time. And now we're actually seeing a decline, and we've gone back to that 15 per day. The data in that gray shaded area, there's a little bit of a data lag. So we're actually right on the cusp of finding out whether we're going to end up getting a little bit below 15 per day. It would be really nice if we got a bit of a respite after all of this time, or continue hovering at that, still significant non-ignorable level. That's 10% of the city's deaths. Next slide. In the context of all of this, again, we have this non-ignorable mortality. What we're seeing is that New York City seems to be really missing the opportunity to suppress those deaths by benefiting from COVID-19 vaccine boosters. So we have this new bivalent booster. It contains virus from the ancestral strain of COVID-19 that was in the original vaccines, and it also contains the sequence from the virus of the BA5 variant, which is part of this Omicron. Sometimes people call it swarm of Omicron subvariants. And so it's updated to be more relevant to the variants that are circulating today. And what we're seeing right now is 99% of New York City residents who are adults, age 18 plus, have had at least one vaccine dose, and the vast majority have completed the primary series, and many have had at least one booster. But when it comes to the latest booster, the bivalent booster, which is what you need to be considered up to date on vaccines, only 17% of adults in New York City have that bivalent booster, and that pretty much maps to the United States average is about 16%. And even more concerningly, only 26% of New York City residents ages 65 and up, who have the highest risk of having a severe outcome from their infections, have had the bivalent booster. So the vaccine at this point is plentiful. Data on the safety of the vaccine is very, very strong. There's just been so much use of the vaccine, and now it's a nice amount of time to observe the effects of the vaccine over time. We can be very confident in its safety. We have no problems with availability. So this is really just a missed opportunity that these 99% of community members who have had their series really need to go back and get their booster to help us suppress this still significant mortality rate. Speaking of the vaccine and the bivalent booster, let's talk a little bit now about the variants that are circulating and what that means about how effective vaccines will be and how effective other tools will be. So next slide, please. So just one more slide. So I think the big thing to note with variants is just as we started to get our heads around what's going on with variants and the alpha, the gamma, the delta variant, people were starting to get their heads around the Omicron variant. The Greek letters went out the window. So, goodbye Greek letters. Now we're back to this alphabet soup of B something and then a bunch of dots and numbers. And this is admittedly very confusing. And the reason that happened is essentially all of the variants since the 2022 holiday season, the 21 to 22 holiday season, when we had that big Omicron surge, which we now call the BA1 surge, all of the variants are relatively close genetically, so sort of close relatives, cousins, if you will, of that Omicron strain that hit so hard. And so all of these go under the Greek letter Omicron. And that's why we have an alphabet soup to differentiate the subvariants of Omicron. So that's why we're here. The next Greek letter after Omicron is pi, personally my favorite Greek letter. And we just don't know, are we going to get a pi variant next, or are we going to have subvariants of Omicron forever? So let's just dig in a little bit more. So if we look at the next slide, we can get here a snapshot of the subvariants of Omicron, what they're doing around the country here on the left, and then what they're doing over time on the right since about the start of November. So to the left, you can see the very latest projections. So this is for the week of January 22nd to 28th nationally. And you can see the dark blue is the dominant variant that is in the Northeast area and in New York City. That variant is called XBB.1.5. I know it's a mouthful. It's a type of an Omicron. So it's part of a sublineage or part of the so-called Omicron swarm. And you can see it's quite prevalent in the Northeast, not so much in the central or western part of the United States, although it is trending that way. But it's really completely taken over in the Northeast. And then looking to the right, this is our national average for the composition of variants. So you can see there's still quite a bit of BQ1 and BQ11. And then in some areas, still some BA5 hanging around. So BA5 is quite closely matched to that second component of the bivalent booster. So, different parts of the country, we're seeing different mixes of variants. None of them, though, are all that different from one another. They're all pretty closely related as Omicron variants. So let's just go one more slide. And here, just to reinforce that idea of, how closely related these Omicron variants are. Here, you can almost think of this as sort of a viral family tree, except viruses don't have a mom and a dad. They just mutate as they go along. But here we're looking at mutations in 9 key positions that are important because they affect how the virus binds to the human receptor. And I think the first thing to think about as we look at this table is when we got Omicron BA1, back when we had that huge surge in 2021 to 2022 holiday time, that was 50 mutations that sort of came out of nowhere. So we went from nothing to 50 mutations in one huge evolutionary leap. And so, that's probably why when Omicron first emerged, it was really able to circumvent a lot of the immunity that we had. And we only had monovalent vaccine at that time. So it was partially able to reduce immunity against infection for the vaccine. And that was probably what led to that huge surge that we saw. But ever since then, instead of more of these huge leaps of 50 mutations, we've had these little hops of evolution. So here, going from left to right, we can see in this case compared to BA2, which is the next one after BA1, the viruses that we've seen that have had 3, 4, 5, 6, 7, 8, and 9 mutations. So that 9 is still less than a fifth of the way to the 50 mutations that we saw with BA1 compared to the ancestral strain or the strain that came before. And so you can see that BA2 branched into the top branch here, BA2 7.5, and you can, we probably some of this alphabet soup you probably haven't really seen in the news because they've been very minor variants. And then the bottom, it branched into BA4 and BA5. And those might ring a bell because BA4 and BA5 were actually dominant in our area, roughly, 3 months ago. And so that BA5 branch led to BQ1 and BQ11, which has been dominant about a month ago. And then the top branch led to another variant, XBB, which led to XBB1, which then led to XBB115, which is what's prevalent right now. So you can see, this virus is hopping along, it's drifting along. XBB is kind of an interesting one because it looks like there were two sublineages that branched and then merged together. Maybe some virus recombined mutations, or maybe those mutations came about in multiple branches. But it's just kind of drifting along its family tree. And as it drifts along, it gradually gets a little bit further away from our immunity, and then our immunity catches up with it. So that's sort of what we're seeing right now. And hopefully this helps to give you some intuition. Probably this sort of family tree is going to keep going along, and we're going to have to keep coming up with more letters of the alphabet as it hops, 2, 3, 4 mutations along to the next variant. Next slide, please. Oops, I'm going to mute my email program, which is dinging here in the background. So thinking about that kind of the science of what's going on there, what are the implications that this has for vaccines, for different tools that we have in our toolbox to combat COVID-19? So let's start with implications for vaccines. And I think a common question that is bouncing around the community is, do I really need a booster again? And do these boosters actually work? There are narratives, I think there are some nuanced narratives that are happening in the scientific communities about how well the boosters work that I think the general public is starting to misinterpret a little bit and think, oh, I don't need the booster. That maybe is part of the reason why we're seeing such low uptake of the booster so far. So I think what has disappointed scientists a little bit is the bivalent booster, although it is better. We actually have evidence now that it is a bit better than the monovalent booster. It's not better by that much. And so here I have just a list of studies that compared a booster. What if you had just gotten the original booster instead of the bivalent booster? And what they tend to show, they use all different strategies. For example, they take antibodies from someone who had one or the other, and they either challenge it by seeing if it stops live virus or something called a pseudovirus, which is a little safer to work with in a lab. And they see how much antibody it takes to stop the virus. And what they find is it takes about 20% less antibody if you've had the bivalent booster compared to if you've had the monovalent booster. So your antibodies, if you've had the bivalent booster, they're about 20% better. That's not, we were hoping they would be many-fold better. They're a little bit better. And so, it's better to have the bivalent than the monovalent, all else being equal, but it's not the huge difference that we expected. So that's why you might be hearing little echoes of disappointment in the scientific community about the booster. Some people are saying the boosters, quote unquote, aren't working. It just means they're not leaps and bounds better than if we had just continued boosting with the monovalent. Now, for most people in practice and everyday life, this does not make a tiny bit of difference because the only booster you can get pretty much is the bivalent. So you're going to get the one that is about 20% better. Maybe we didn't need to invest all the effort into creating it because it's not leaps and bounds better, but it's here and it's pretty much what you're going to get. Now, the key message is all of these studies, they're comparing what if you had gotten a monovalent booster versus getting a bivalent booster. But that's not really the comparison that people should be thinking about in their decision making. The really key comparison is, should I get the booster or shouldn't I? And the key message here is getting a bivalent booster is much, much better than getting no booster at all. So whether it's bivalent or I don't know if you end up in some strange vaccination site that's still offering monovalent, I don't think those are out there, but that would be fine too. Boosters still boost. They still restore protection. They provide some temporary protection against becoming infected in the first place, although that's not perfect. and then they provide very good infection against hospitalization and severe outcomes, such as death. So, and also we're accruing more and more evidence showing that they also prevent long COVID. So definitely get the booster. It is clearly the better choice compared to not getting one. And to make sense of all the dialogue out there about whether boosters work or not, it's just comparing how much better is the bivalent than the monovalent, and the answer is a little bit. Now, the other major topic that I've heard out there that people are thinking about is, how often am I going to need boosters? Is this going to look like a flu shot where you try to time your shot and you try to get it annually around the same time every year? Or is COVID going to look different? And although there has been some messaging around eventually this could become an annual vaccine, based on the situation we have now and in this moment, I would say that an annual vaccine is not going to offer optimal protection, especially for people who are quite vulnerable, or for people who are interacting with someone who's quite vulnerable and who really want to avoid becoming infected. And so my general rule of thumb is, if you really want to avoid COVID, aim for getting a booster every 4 to 6 months, because that's about the window of time that the vaccine is most protective against becoming infected in the first place. Annual vaccination might be fine if you kind of don't mind coming down with COVID, that you have some reason why you don't want to be getting boosters that often, and you're willing to suffer through becoming infected and having flu-like illness. It's going to protect you from hospitalization. It's going to protect you from a severe outcome like death. For me personally, I interact with people who are elderly very closely, very frequently. And so I do want to avoid infection in the first place. And quite honestly, I would rather get a shot and just plan to lie low for a day while I recover from any symptoms from the vaccine, rather than having to go through even a so-called mild flu-like illness, which is just still very unpleasant and hard to time. It's going to come at the most inconvenient possible moment, surely. So for that reason, for people who don't mind going ahead and getting that vaccine a bit more often, that is the way to have the best protection. Now, eventually, we may see that COVID settles into an annual pattern. So instead of these constant waves that never seem to go down, maybe COVID will start acting more like the flu, where we have a COVID season. And that might be the time that we can begin to think of COVID annual vaccination in the same way as flu vaccination, where the current flu vaccine also only gives us about 3 to 4 months of protection, but we can time it with the flu season. By now, we know so much about global trends, because flu has been with us for so long that we can even see, this is when flu is starting to rise in Australia, and that will predict when flu is going to rise in North America. We really understand the global patterns well. And so once we can understand, and this new pandemic really settles into a global pattern that's repeating and predictable, then we can start thinking about when should we time it each year to have the most immunity. But clearly we aren't there yet. This pandemic is still pulling new tricks out of its hat. It still hasn't fallen into any predictable annual pattern. And so, I think the best strategy for those who are willing to get vaccinated regularly is that 4 to 6 month rule of thumb, in my opinion. Next slide, please. Now, what are the implications then of these new variants for antibody and drug treatment? So we talked about vaccines, needing to get vaccinated relatively regularly for people who do become infected, especially those who are unvaccinated or who are at risk because their immune system is compromised or because they're elderly. We need to think about what's the action that you would take after that infection occurs. And so there are some implications that the new variants have for what's available for people beyond vaccination. The first is, and this has been the case for a few months now, so no change since probably November-ish, is that there was a monoclonal antibody treatment option known as bebtelovimab, which it turns out is not effective against the variants that are currently circulating. So that option had to be taken off the list of options for treatment of COVID infection. And so, we still have some great options for treatment, but we did have to take this one off the table because the new variants have mutated in ways where this antibody is not effective anymore. A similar thing has happened with another monoclonal antibody. It's known under the name Evusheld, and it's actually used for pre-exposure prophylaxis or PrEP. So for people who want even more protection than the vaccine, or people who are so immune compromised, the vaccine might not work in them. It used to be they could get regular injections of a protective antibody, and unfortunately that antibody is now no longer effective. And I'll talk a little bit more about that in a moment, because that's a real paradigm shift for those people. The good news is the first line treatment for people who are able to take it, who don't have drug interactions, which is Paxlovid. It's an oral tablet that can be prescribed and taken in the home, is still effective against current variants. So that's great. And then we have a second line option, which is an injected option, remdesivir, which is also still effective. So we still have great options for treating COVID. It's still very important to diagnose infection early for people who are going to go on and seek that treatment. We just have lost a few options because of the evolution of the variants, particularly the monoclonal antibody options. And then I want to close, there's some bad news here. I want to add some good news, which is there's been more research now to try to understand the effect of treating COVID soon after symptoms appear on the risk of long COVID. And so this is a study from the VA looking at the risk of long COVID over time for people who received Paxlovid treatment compared to people who received no treatment for their COVID infection. And I'll preface this by saying this is not a randomized trial, so this is an observational study. They did control for a number of things, and they looked at many different symptoms here. So it's an exciting observation, but it's not the highest level of evidence. But at least preliminarily, it's looking really good. So you can see that the risk of long COVID symptoms, so this is over time, the percent of people who are living without long COVID since their infection. And you can see that proportion is much better with Paxlovid. So what this seems to be saying is getting treatment for COVID, not only does it reduce hospitalization and death, which is the real reason why we have been recommending this, or why providers have been recommending this, but it also reduces the risk of long COVID, whether someone avoids hospitalization or is hospitalized. So this is great news, and all the more reason to use these medications that are still effective against current variants. Next slide, please. So I just wanted to talk a little bit more about the main shift, and this shift is very, very recent, so this might be worth discussing. I think last Thursday, January 26th, the FDA updated the emergency use authorization for Evusheld, and then just that Friday, January 27th, the CDC updated their guidance to remove this as a recommendation for people who have compromised immune systems. So I put a crying emoji here because it really is a shame that people who have compromised immune systems, who might not respond well to vaccination, might not get full protection from the vaccine, no longer have this option. So what this was an antibody that could be injected on a regular basis every however many months to protect a person from becoming infected by COVID-19 and reduce the severity of illness. So it's sort of something to add on top of vaccination for people whose immune systems don't respond well to a vaccine, or for people who can't get the vaccine. And unfortunately, that option no longer is available because the very latest variants are not reacting well, not susceptible to this monoclonal antibody. So right now, what the CDC is recommending is pretty basic stuff, sort of non-pharmaceutical measures plus vaccination. So, definitely get an updated vaccine. For people who have compromised immune systems, they do recommend some additional doses of vaccine in some cases. But making sure that the person is up to date, has had all the vaccines that they're eligible to get. And then the rest of this is really non-pharmaceutical things like improving ventilation, spending time outdoors, washing hands often, wearing a well-fitting mask in crowded places, getting tested if you've been exposed or if you have symptoms. And then just the third one there from the left, learn about testing locations and treatment options before getting exposed or sick. So this is really good advice for anyone who is vulnerable in our communities, anyone in your life who could is at higher risk of developing COVID disease because they're immune compromised or they're elderly or they have complications or medical conditions. It really, what the recommendation is make a plan for if you were to test positive today, what you would do. And that's so that people are not scrambling, trying to reach their doctors and having delays in getting treatment if they test positive. So the reason for this is that these medicines that do still work, Paxlovid, remdesivir, they are great, but they really work best if they are started as soon as possible after a person tests positive or develops symptoms. And so we don't want delays because the person hasn't talked to their doctor about which of their medications they can take together with Paxlovid. And then by the time you have that conversation, it's been 2 days, or you test positive on a Friday night, you can't get a hold of your doctor till Monday morning and you've lost all of that time. So making that plan ahead of time, talking with doctors, talking about the medications the person is taking, can they safely stop any medications that can't be taken with Paxlovid for that 5-day treatment course? Making that plan ahead of time is really critical so that people can then get that medication as fast as possible when it's going to work best. So, I hate to say it, there's not that much else that can be done right now for people with compromised immune systems until hopefully we get a new pre-exposure prophylaxis option that works against current variants. My heart really goes out to people who used to be able to get that extra protection who don't have an option now. Next slide. So looking ahead, really from where we are right now, future variants are our biggest unknown in terms of what the future is going to look like. As many of you know, there was a very large COVID surge in China, and there was a lot of concern because the population of China is so large, so many chances for the virus to mutate that could produce a new variant. But evidently that has not happened. And really scientists don't have a good idea of why or what it means. Did we just have a lucky break that the Pi variant didn't emerge at that time? Is it still a matter of time? Is it out there percolating and it's going to pop up at any moment? Is Pi never going to come? Or are we just going to have this Omicron swarm forever? We really don't know. But what we do know broadly is that viruses evolve in a Darwinian way. There's evolution. And you can think of evolution as the Red Queen in Alice in Wonderland, who says it takes all the running you can do just to stay in the same place. And if you want to get somewhere, you have to run twice as far. And what that really means is the virus is always changing, and we have to keep going. We have to keep changing. We have to keep working just to stay where we are now, just to keep the level of control that we have now. And it's going to take even more effort if we really want to defeat COVID as a public health problem. And that means we need to be constantly developing new vaccines, new drugs, new antibodies. We've already, as I just mentioned, lost the pre-exposure prophylaxis option. We really need to be working to get another option against current variants and really doing everything possible to stay one step ahead of this virus. We should expect that the tools that we have will eventually burn out because this virus mutates so quickly, but that doesn't mean we should stop trying. We need to be constantly developing new tools, constantly learning and fighting. And part of that is in the community. We need to fight complacency. We need to continuously strengthen public health systems as if the Pi variant is right around the corner, because it truly could be. And so just some ideas for that is something we can work on during kind of non-emergency times when COVID is there, but it's not an urgent front of mind situation, is to work to improve indoor air exchanges. In many settings, we have ad hoc systems. Schools have these air purifiers set up in the classroom that eventually are going to stop working. They're kind of temporary fixes. We need long-term sustainable solutions to improve indoor air quality, air exchanges. And that has multitudes of benefits other than just preventing COVID. It improves indoor air quality, which helps people function well and learn and have good long-term health. We need to start developing pre-thought out plans for if we were to have a really bad variant. So if we did get a pi variant and it was very severe, or honestly, if we had a brand new pandemic, maybe an influenza pandemic or some other virus, Ebola, we don't know what it's going to be. If we need to shelter in place again, how could we do that in a way that is more equitable, that protects the livelihoods of the most vulnerable, that protects children, protects education? What would be our playbook if we had to shelter in place again? We really need community voices to be a part of that, so we have a plan that is not going to be as devastating as the COVID lockdown was. We also need pre-thought out plans for updating vaccines. So if we have a variant that the vaccines don't work so well against, thank goodness the vaccines are holding up well in terms of preventing hospitalizations and deaths. But if we need to produce a new vaccine, we need the production plan there. And if we need to distribute a new vaccine, we need the distribution plan there. And many of us remember how crazy it was when we had the vaccine for the first time in short supply, and it was so unclear who's eligible. We didn't have materials in all of the languages that our communities needed. There were so many barriers that made that distribution inequitable and really non-ideal. We need a better playbook. We need improved testing and contact tracing. New York State attempted to roll out digital technology for contact tracing with an app. And I think it's pretty clear that that did not work. So we need to engage communities. We need to understand what people need in terms of privacy, in terms of benefits that they might get through tracing, so we can actually contain transmission with tracing, which is something we haven't done before. And we need more effective and trusted public health communication. So every time the recommendations change and it's confusing, we really need people positioned in the community to make sure that those recommendations can be trusted and understood in our communities. So next slide, I just wanted to share this really wonderful article that was published on January 28th, so just a couple of days ago, in the New England Journal of Medicine by Wafa El-Sadr and colleagues, talking about facing the new COVID-19 reality. So it's a really nice read if you manage to log into the New England Journal of Medicine, talking about how, relatively speaking, we're in a pretty good place right now, but COVID is still a problem. It's a non-ignorable problem. And then also thinking about what we need going forward. And I just want to read this paragraph because I think it really speaks to the role of community health workers in putting us in a better place for dealing with COVID. So they write, most important, attention to the engagement of trusted community leaders and spokespeople is required, as is listening authentically to communities from the start. Rather than focusing solely on what is being recommended, it's equally important for public health leaders to focus on how recommendations are communicated and disseminated. Early engagement of community representatives is critical so that various aspects of anticipated guidance can be discussed in detail, including rationales, trade-offs, and the most appropriate communication channels and formats. Engagement must not only come in the form of an emergency response, it must involve a consistent presence, which can then be leveraged and activated further during times of urgent need. So I think that is really the big lesson from COVID-19, and really probably one of the most important things that we can invest in now to be better prepared. And then my last slide here, just to summarize what we've gone over today before we turn to your questions. So one of the main things is, although we are in a better place, COVID deaths continue at an unignorable rate. So the rate right now is about 10% of all deaths of any cause are COVID deaths. And sort of exhaustingly, we have unabated transmission. So the waves have blurred together and we have this constant rate of transmission and death, more or less, with some bumps and ups and downs. And it's really unclear if it's going to continue that way indefinitely or if something is going to change. But the really alarming change would be if we get the next Greek letter after Omicron, which is pi, if we get that pi variant and then we get another surge and really not knowing what that would look like in terms of the severity of the disease, the transmissibility. Who knows, maybe different populations affected. We really don't know, but we need to be ready. And so to do that, we need to address vaccination gaps and disparities. The bivalent booster rates are low, only 16, 17%, technically 16.5% of New York City adults are vaccinated. That's a huge missed opportunity. And just to remember, in our messaging, there's been a lot of confusion with scientists saying, oh, the bivalent, it's not that good. Well, what that means is it's not that much better than the monovalent was, but it is much better than getting no booster. So since the monovalent has been phased out, really the relevant question is get the booster or not? And the answer is get the booster. It is much, much better than getting no booster. And then finally, just the state of treatment options and other prevention options. The big change that has just happened is that there is no more pre-exposure prophylaxis option. And one of the treatment options also is off the table now with the latest variants. But importantly, key treatment options still work against new variants. So Paxlovid and remdesivir still work. Paxlovid is our first-line option. There's new evidence now suggesting it might also reduce long COVID. So all the more reason to be ready to pre-think that plan with your doctor to have Paxlovid available as soon as possible after someone tests positive or develops symptoms. And there are other options. So if people's doctor says, you really can't pause this medication even for 5 days, you should not take Paxlovid together with this medication that you're taking. Don't be discouraged because there are other options. So the next one on the list would be remdesivir for most patients. So that's what I have to share today, and we have some time for your questions. I'll turn it over to Val, our wonderful moderator.
Thank you, Dr. Anna Burstein, for this informative discussion about where we are with COVID. And I also want to take time to thank our CHWs that are here on this call, seeking to share this information with their community members. Our first question is, what do you think about the recent report of there being a link between the Pfizer bivalent booster vaccine and an increased risk of stroke? How can I confidently recommend getting the booster to my clients, especially the older population?
So that's a good question. And just to give a bit of background here, there's been so much use of COVID vaccines, and to make sure that those vaccines are completely safe and that there are no safety issues that maybe weren't picked up in the vaccine trials, there are multiple ways that the government is monitoring for vaccine adverse events. And those methods are present in many different countries, monitoring to make sure that the vaccines are safe. And so what's happened is just one of several vaccine event monitoring systems run by the US government picked up a very weak possible signal that seemed to positively correlate the Pfizer vaccine with stroke. But there's something fishy about that signal because it isn't there in the Moderna data, and it isn't there in any of the other ways that vaccine adverse events are reported. So we also have something called the VAERS, the Vaccine Adverse Event Reporting System, no association in the VAERS. In the Canadian vaccine reporting system, there's been lots of vaccination in Canada, absolutely no association with stroke. The trials of these vaccines were very large and showed no association with stroke. So probably this is just an aberrant signal, just a false alarm, so to speak. But our government is being responsible and saying, hey, we did pick up this slight association, and we're going to monitor and see if that association stays around in the data. What I take this to mean is, there was a blip in the data, and it may, it may be something, but more than likely it's nothing. And really, out of abundance of caution, our government is just being very open and transparent with us with, hey, there was this blip in the data. Let's please watch for this. It doesn't mean we shouldn't be vaccinating, but keep an eye out in case we learn something new. So I guess my recommendation to providers, to community health workers is do keep an eye out. If you hear about any of this in your community, do report it to the government, but it's really not solid enough data to change anything that we are doing right now. And it's a good sign that our government is letting us know, even if it might not be real, that they saw it in the data. It just shows the transparency that we are getting.
Yeah, thank you for that answer. I know that according to the CDC, 80% of individuals 60 and older actually have better protection when getting vaccinated.
Right.
Our next question, what do you think about the recent report that there may be a link between Pfizer bivalent booster vaccine and an increased risk of stroke? I'm sorry. Are side effects from vaccines and boosters still pretty much the same, or have they gotten more severe?
So the side effects actually from the boosters, I think the totality of evidence suggests it's actually less than what we see in the primary series. And in particular, the second dose in the primary series seems to be the one that people feel is a bit of a whopper, and they're sort of down for the count for a day or two. So if for those who haven't had their primary series yet, that's really the second dose in the primary series, or it might be a good idea to plan that for a day when you are off of work, not having to do a lot of heavy lifting around the home. And you can just kind of relax in front of the TV and recover from that dose. Interestingly, in children, there have been some signs that the vaccine can cause a very temporary inflammation in the heart, which the children then do find that it's just a sort of temporary thing. And what they found is to prevent that from happening, what you can do is space the first 2 doses of the vaccine apart by 8 to 12 weeks. So what might be going on there is when we first rolled out that primary series, if you think back to that time, I don't even like to think back to that time. It was such a horrible time. People couldn't wait to get their full immunity, right? Because there was so much mortality. COVID had completely upended everything. The hospitals were full. And so the recommendation was to get those first 2 doses as close together as possible with them still being effective. So 3 weeks for Pfizer, 4 weeks for Moderna. That's about as close together as you can get vaccines, because waiting another month was a big deal at that time. But now that things are not that way, and for people who haven't had their primary series yet, spacing them 2 or 3 months apart is not such a big deal. That might be the better option for people who are concerned about side effects from that second dose, and in particular for teen and tween children who they sometimes see that they have a bit of heart inflammation. They're down for the count for a bit after that second dose. So to avoid those symptoms, space the first 2 out. And then I think because the boosters we're only getting every few months, so we're not getting them 3 or 4 weeks apart, people tend to find that the symptoms are milder and they're not much different from, say, the first dose.
Thank you. Our next question. Some community members believe that vaccines cause seizures and point to videos circulating online proving their point. How do we counter this type of misinformation?
Yeah, I mean, countering misinformation it's a challenging thing because people see what they see online. I've had this experience with people who are not English speaking, and there's a lot less curation of the foreign language content out there that people get exposed to. So, having those conversations when someone is really convinced of something and getting to the heart of what they're really worried about and getting them to the truth, it's not an easy process, and it's about really listening before you speak and having a relationship of trust. So I don't want to minimize the difficulty of that, even though there is no association that we know of between the vaccine and seizures. One story that I heard that really touched me actually was from a woman who had to get some vaccine. I think she hadn't had her pertussis vaccination as a child, and so she needed to go and get her pertussis vaccine. And she had scheduled her vaccine appointment, but she was starting to feel a little queasy that day. And so she decided, oh, you know what, I think I'm going to cancel my vaccine appointment. And then that night she started vomiting blood. And it turned out she had had food poisoning or something, had some really bad gastroenteritis. And she was thinking, gosh, if I had kept that vaccine appointment and I had gotten that vaccine, and then that evening I was vomiting blood, I would be completely convinced that the vaccine, right, had caused me to have these symptoms. And when you're vaccinating basically the entire country, just by the numbers statistically, that's going to happen, right? There are going to be people who get the vaccine and that evening some horrible thing happens that would have happened anyway. And of course they're going to think it was the vaccine if that's what they had just done. So you're always going to find someone out there with a story like that, but you'll find just as many people who say, oh gosh, if I had had my vaccine today, that's what I would be thinking. But clearly that's not what it is. So I think that story can help to put some people's feelings kind of calm
at ease.
down.
Yeah. Okay. So if someone is asymptomatic, should they take COVID treatments? This person is asking because long COVID can affect anyone who has had COVID. Those who have had severe symptoms, those who have had mild symptoms, and those that didn't have any symptoms at all.
So that's absolutely right. So I think the evidence, like I mentioned, is not great yet. We have this observational study of US veterans that does suggest that getting Paxlovid in a timely way could reduce long COVID, but that's not a randomized study. It's not a representative study. So we still have more to learn about, does Paxlovid treatment actually reduce long COVID in a particular population and asymptomatic people. There's a lot more science to be done there. But I would say in part, you also want to think about the risk of the person involved. So if you have someone with a compromised immune system, you have someone who's elderly, I'm thinking about my 93-year-old grandfather, right? Even if they were to test positive and have no symptoms today, they could certainly develop symptoms later. And you don't want to wait until it's too late. So that's really that's a nuanced decision where you want to think about, what is it going to take to get this person on treatment? For example, are they going to have to stop some other medicine that's beneficial? What is their risk in the first place? Are they young and healthy, or are they immune compromised or have some risk factors? Really, think that through and make a decision that's really customized to that person. Yeah, I think I would say, and that's probably true also if you are symptomatic, right? People who are young, fully vaccinated, don't have any risk factors, they may or may not decide that they want to take Paxlovid. That becomes more of a nuanced decision of the pros and cons for that person. Whereas I think it's a much easier decision for someone who really is at substantial risk of disease.
Thank you for that. How can we as a CBO approach the community or even have a conversation about the rejection of the bivalent vaccine? The community doesn't even want to get vaccinated.
Yeah, and it's, we see it by the numbers, and you out there are seeing it, on the ground in your communities, that this bivalent booster has been a real challenge. And, part of it, I think the scientific community, in the interest of transparency, has been having all these debates about what is the booster that good. And I think it's just completely confused the issue, because the scientists are talking about how much better is the bivalent booster than the monovalent. But people out there just want to know, should I get it or not? That's really the decision.
Exactly.
Getting. So I think part of it could just be clearing that up, because I don't think that the scientific community has communicated that well at all. So just clearing up, bivalent, only about 20% better than the monovalent, but much better than nothing at all, right? So, boosters boost, and we still see that very clearly. We see that people produce lots more protective antibodies when they get the booster. We expect that people will have at least a few months of reduced risk of getting COVID in the first place. And it's going to boost their protection against hospitalization and death, which we really worry about, and long COVID as well. So lots of benefits from the bivalent booster. And I wish I had a better answer, but really we're leaning on all of you to communicate that better, because it doesn't seem that the scientific community has done a good job of that.
I just want to actually with with all of these boosters that we are getting, is it going to come to a place where we actually develop herd immunity?
That's a good question. Herd immunity has been a dream for COVID. Since the very beginning, some countries have thought, oh, we'll get herd immunity. What it turns out is the case, though, is this virus mutates quite a bit. And it used to mutate by these huge leaps. And nobody really knows why, but it stopped mutating in huge leaps. And it started mutating, like we saw in that diagram with all the lines going from left to right in these kind of steps of a couple of mutations at a time. But it's doing that just fast enough to prevent herd immunity. So it's kind of, herd immunity is just out of reach because the virus just kind of dangles it and then it yanks it away, right? It just manages to stay ahead of how our immune system is trying to catch up to it. And we just don't know. Maybe eventually the virus will run out of ideas and will be immune to everything that it can do. Maybe it'll keep one step ahead of the human immune system indefinitely, or kind of the worst case scenario, maybe it'll take another leap and we really don't know what that will look like. And we'll sort of be in a similar scenario as where BA1, that first Omicron wave, where we didn't know what it was, but it was just going crazy and surging in our communities. So either of those three things could happen. And I don't think science has an answer right now about which one of those is more likely to happen.
Thank you. So what is the current situation with COVID worldwide, specifically in China and Japan?
So we had this COVID surge in China, and that was particularly because of the relaxation of these rather stringent lockdowns. It's really, I don't know if I could do justice to that question in a short amount of time, because there are a lot of questions about reporting and about how well the health system really is holding up to such high rates of infection. But what we've seen in the past couple of months is, for example, an airplane full of people that departed from China had a very high proportion of people testing positive for COVID-19 on the plane, suggesting that there's quite a high rate of infection in the population. And it's a huge, huge country. So, what the implications for us, I think, here is it seems like the perfect storm for a Pi variant. But on the other hand, it hasn't happened yet. But I think now is a time to really be vigilant and get our preparedness in place, because it very much could happen.
Are side effects from vaccines and boosters, I'm sorry. Okay, will we need to actually get the boosters every year, and what will that look like, especially since we are also getting yearly flu vaccines?
Yeah, that's still an unanswered question. I think the CDC has hinted at that, the annual COVID vaccine, but from what we see right now from a scientific standpoint, it doesn't look like we're ready to transition yet to an annual COVID vaccine, because that works well for something like flu, where the season when transmission is going on is only about 3 or 4 months long. And so you can get the vaccine and then have coverage for the season, and then you don't need the coverage so much for the rest of the year. But because COVID is just this constant thing, one subvariant after another, it seems like for people who are really at risk, the best coverage would be year-round coverage, and that means getting the booster every 4 to 6 months, honestly. So that might not be for everyone, right? People who are healthy and they can cope with getting infected and being down for the count, but not in the hospital. The annual booster might not be enough, but for the most vulnerable, when I'm on the phone with my grandfather in his 90s, that 4 to 6 month rule of thumb is what I personally think.
Can you tell us what the impact is on the underserved communities regarding the issues of inadequate supplies as we begin to see shortages of amoxicillin as well as pediatric ibuprofen and acetaminophen?
Yeah, I mean, it's a tough thing. So with those particular medicines, things got a little bit weird, not because there's plenty of those medicines in the world and the factories are cranking out enough for everyone, but because there has been a bit of a run on supply particularly over the holiday season, not just because of COVID, but because all the kids were getting all the colds, RSV, influenza, rhinovirus, human metapneumovirus. There's so many different viruses that just families got hit with, that certain stores were running out of these medicines. And as is too often the case, it's our most vulnerable communities, the places where, you know, it's a trek to go to the next pharmacy, and you know, maybe the pharmacies aren't going to be going that extra mile to make sure that these products are on the shelf. That led to some shortages in some places, or you know, it's not so easy to get an extra hour up of work to go and get those medicines. So I think it's a reminder that we need to make sure that there's equal access to medicine for all and prioritize our most vulnerable communities always. But thankfully, this isn't some kind of national emergency. There's still plenty of those medicines to be had.
Thank you. And another
I
question.
think, Val, I'm so
I was going to
sorry.
ask
We,
if
we are we are at time, and I just want to thank Dr. Burstein and Val for such a really wonderful webinar with really valuable information and excellent moderation. I also want to thank our NYU Community Health Worker Research and Resource Center and our team here, as well as New York SEAL, and the NYU CUNY Prevention Research and Resource Center. There is a poll that has popped up on everybody's screens. Please fill that out. It helps us plan for our future events. And please stay tuned for the recording and the slides from today's event. And keep doing all the amazing work that you're doing, getting communities vaccinated. And yeah, I hope everybody has a lovely rest of their day. Thank you so much.